Thank you very much for inviting me, and I have a great question that was given to me. Do all patients with syncope need to see a cardiologist? And this reminds us, of course, that syncope is not a trivial matter. Syncope may fall on the spectrum of disorders that sometimes lead to a lethal outcome. And so it certainly is insightful to ask the question, do all patients with syncope need to have a cardiac evaluation? Last year, the ABC News came to the Cleveland Clinic for 3 days and did a lot of filming in our lab, and apparently Diane Sawyer sent a film crew out there. She had had an episode of syncope herself, and she was interested. And somebody made the statement to the press, it wasn't me, that said, not only do all patients with syncope need to be seen by a internist, but should also see a cardiologist as well, because syncope can lead to sudden death. And so when that statement was made on ABC News, the next day we received 250 requests for consultations. So, you know, they may have gotten it right a little bit, because, you know, their syncope can be a warning sign for future sudden cardiac death. And certainly that is evident in the Framingham data, of course, which was a large cohort of patients which were followed for many decades in Massachusetts. And in the patients who had syncope due to a cardiac cause, well, the mortality was very significant. In fact, it was double the patients without syncope. Now, also on this slide, if they had syncope and it was felt to be due to vasovagal syncope or to a neurally mediated mechanism, then their mortality was the same as controls. So in those cases, if you have cardiac syncope, obviously that's places you at an increased risk. Now, you could argue that this is an epiphenomena because they were going to die from their cardiac disease, but certainly it points to some potential concern. So, do all patients need to see a cardiologist? Well, why ask the questions? Well, you know, there's been a lot of changes now going on. There's a lot of the Affordable Health Care Act, CMS, a lot of places are now more tightly regulating your access to medical care. And so in the future, the primary care physician, the PCP, is going to be on the front line for just about every disorder there is. They're going to have to make a lot more triage judgments than they have in the past. Already we're seeing, you know, significant reductions in reimbursement happening all across the board in medicine and not just cardiology. And so we have to be concerned that patients may not be able to get all the specialty and subspecialty they want. For example, many of the healthcare payers, including the Cleveland Clinic healthcare system, deny tilts routinely. They feel that they're not appropriate in all cases, and so I frequently have to meet with, do a peer-to-peer just to get a tilt approved. And it's going to get worse because the population is aging. We're getting older and older and older, and syncope incidence and prevalence is going to go much higher. We need to have a streamlined approach when you're dealing with a syncopal patient. Otherwise, you're going to just bankrupt the system. If you order every test for every patient, it's going to just have skyrocket healthcare costs, and we're going to talk a little bit more about that. So it depends who you ask the question to. If you ask cardiology administrators, like our own administrator, sure, every patient should come on down and see a cardiologist with syncope. However, my own colleagues in EPS say, no. If they have syncope, let the PCP work it out first, especially if they have POTS. My group doesn't like to see the POTS patients. And then, of course, insurance providers and HMOs. They have specific guidelines, and some of you may be in those groups. For example, I've seen some of these guidelines. They're not allowed to refer a patient to cardiology unless they've met A, B, and C, and we'll talk about some of those things. Now, I think everybody in this room who's a primary care physician would say, no, they don't all need to go to the cardiologist. And many of you can do an appropriate, complete, comprehensive evaluation of the patient, determine which ones you need to triage, and act appropriately. Now, Many of you have seen that probably on the internet. Obama was rolling out the troubles with the website, and this woman behind him in the red proceeds to collapse and faint. And it's an interesting little anecdote. She turned out, she gave an interview afterwards, she's 5 months pregnant. And because of that, she didn't want to drink any fluids in case she had to go to the bathroom during the press conference. So she stood up there and continued to get symptomatic and get close to fainting, and eventually President Obama caught her as well as one of the other participants. Now, her husband was in the audience, and he was looking at her, and he knew something was happening, but he was afraid to run to the stage that he'd get shot by the Secret Service. And so the other interesting thing is that this has been posted on YouTube, and the haters and the birthers and everybody have commented saying it was staged, and Obama was just doing it to show off. I don't know if that's true. All right, so we'll forget that. Let's just see here. There we go. So what are the current guidelines that we should be following when we approach a patient with syncope? We want to have some guidelines, some framework that we're following. The most recent guidelines are from 2009, and they're European, but they do reflect a lot of American thinking and American thought leaders, and including one of my own colleagues, Dr. Chung at the clinic, who participated in the preparation. And this is a very good document. It's pretty long. It's 300 references. It's about 50 tables, but it is very helpful, and it's geared towards anybody that has to deal with syncopal patients. They don't say in the guidelines who should see the patients. They say anybody with experience should see the patients. They do emphasize the need for a streamlined approach. Now, I've been meeting with people that are in our own electronic medical record, EPIC, for many of you that work for the clinic. The EPIC now is going to incorporate that ICD-9 code 780.2 for syncope. If that code is entered as a diagnosis, there's going to be stuff that pops up that will be giving some clues to what needs to be done for the patient. So that's going to be coming down the road, just like what we have for heart failure now, when they remind you that they should be on an ACE or they should be on a beta blocker. Not just for the diagnosis, but the cardiologist, I think, can help you with the quality of life concerns. I mean, particularly occupation and driving is a question I get asked all the time. Even a single episode of syncope can have a major impact on a person's occupation. They do emphasize in the guidelines that there should be a need for a place that a patient can go that has experienced doctors that can handle all forms of the syncope, and those are like the syncope centers. And we had the first syncope center at the Cleveland Clinic back in the 90s with Dr. Fuad, and Dr. Maloney was the first people to recognize the need for that. What is it? So just deal with some numbers here. Up to 60% of the population may have a syncopal event in their lifetime. And many people in this room probably have fainted. There's 500,000 new patients a year that report syncope. Now, those are patients that show up somewhere and get that ICD-9 code. So there's probably many more, because the first time many people have syncope, they don't even seek medical care. They just, they realize that it was a vasovagal faint. And so many, almost 50% of people probably don't seek medical care until they have their second event. And I hear that all the time. Or they may not go to the emergency room after their first one unless they're hurt or something and present in your office. When they do go to the emergency room, it's a pretty significant number. Up to 3% of visits are related to syncope. Almost half of those patients do get admitted. So the staggering healthcare costs, up to $2.4 billion estimated annually. And it is the most common in-flight emergency. If you've ever been on a plane when somebody fainted or has a problem, it is one of the most common things. The New England Journal reviewed all the healthcare emergencies that happen on planes, and more than 30%, more than a third were syncope or pre-syncope. And I hear this all the time. Patients are fearful when the doors close. They are fearful during takeoff and landing. What's interesting also in the study is that it was something like 50% of the time there was a physician on board who helped the patient. What is the definition? It's important to have definitions when you deal with syncope. It's a complete loss of consciousness due to reversible causes without focal neurologic deficit caused by cerebral panhypoperfusion. Because of that framework and that definition and that paradigm, it excludes all the other things that cause people to pass out. We call those TLOCs, total loss of consciousness, and that's seizures and TIAs and metabolic etiologies and psychogenic and trauma. Those are all TLOCs, but syncope is a specific diagnosis. It's important to classify things because, fortunately, the most common causes of syncope are the relatively benign ones, the vasovagal syncope and the orthostatic hypotension. Now, this is from my friend up at the University of Minnesota. This may be skewed a little bit because these may be recalcitrant cases, but in their experience, you know, they classified all of them. The very severe, potentially life-threatening ones, you know, comprised only about 20% or so. But up to a third remained unexplained. And that still is going on. In all studies that have been done looking at syncope, up to a third remain unexplained. I don't need to go through the terrible long list of things that it could be that are very severe. It's going to be with a few simple questions and a few simple inquiries to the patient and a few simple tests, you can usually rule out very severe things just by talking to them. By age, younger patients obviously, by age, younger patients usually have vasovagal syncope. Older patients, it's usually cardiac or orthostatic hypotension. The syncope in the elderly can be really challenging because many times they have just falls and they don't realize what happened. They don't realize that they passed out. They just find themselves on the floor, or they say they tripped on the carpet, or they say they stumbled and they don't even realize they fainted. So there are these clinics now in England, and a clinic is now starting to get a dizzy woozy clinic where people with unexplained falls, and in England they call them fits, falls, fractures clinics. And it can be very difficult to try to pick those people out. It may be multifactorial. They may have arrhythmias, they may have severe orthostatic hypotension, or they may have chronositis, hypersensitivity, or sick sinus syndrome. And sometimes it's all of the above. They can have all of the things. We published this 25 years ago. We thought it was reflective of what we needed to do. I just show it now for historical, aspects, because we kind of emphasize, we need to do this neurologic thing. Well, this is the primrose path. Now, this is what eats up a lot of healthcare dollars. Patients going for MRIs, going for EEGs, going for carotid ultrasounds, and they're always negative. They're always negative. So before you go this route, and probably you should, if you're thinking this route, probably a neurologist would be the way to go. He might order them anyway, but they really eat up a lot of healthcare dollars. So the guidelines then kind of summarized what the best way is. Now this looks kind of small, and it's kind of simplistic, but you're going to see the patient. You're going to make a determination. You're going to do an EKG physical exam, listen to their history, and you're going to say, I know what this is, and you're done. You're going to say, well, there's some high-risk factors here, and we'll go through those high-risk factors here in a couple minutes. We're going to admit that patient for expedited evaluation. Or there's no high-risk factors, but still there's a suggestion of cardiovascular factors. You're going to refer them to cardiology. So that's kind of simplistic, but it is a good framework. When you see the patient in the office, you're the first responder for their syncope. You got to ask yourself two questions. Is this a warning sign of sudden death? I mean, my gosh, this sounds bad. I should get him into the hospital. And if it doesn't sound bad, well, it sounds like a vasovagal faint. What's the risk of recurrence? If he has a recurrence, he may get hurt. So we should give him some pragmatic guidelines about that. There's a publication, British Journal of Cardiology, that does these top 10 lists all the time. And they just did one not too long ago on a top 10 list of things to do before referring a patient for cardiology evaluation. And it was written, it's very nice. If you have a chance to read it, it's a very nice little short paper. It's written by a guy named Sutton, who is electrophysiologist to the celebrities over in England. He likes to claim that he invented the tilt table test, but everybody knows that the Cleveland Clinic invented the tilt table test. He's a celebrity cardiologist to celebrities. He did Elton John's pacemaker and some other people's. But it's a nice little paper. So when you see the patient's history, you got to start with that. You got to talk to them about what happened, and we'll go through the list of things. Also in your office, you're going to do an EKG. Nobody should leave without an EKG. You're going to do orthostatics, not just immediate, but 1 minute, maybe 3 minutes, maybe 5 minutes, if you can have your people do it. And then you're going to go and try to synthesize or proceed with the appropriate tests that you need. Individualize is the word I was looking for. Individualize the approach. They don't all need every test. But you're going to try, the sine qua non, of course, is going to be to try to capture an event. You're going to make a determination. Oh, maybe this was vasovagal. I don't think it's going to happen again, but it could. So let's do some simple things. They should get a CBC. They should get some lights. And you may decide that you want to do a Holter, which we'll talk about, ambulatory monitoring. You may want to do that. And you're going to decide when you see them, admit, reassure, or refer. And we'll go through that. And the history, you'll have this in your handout when you get it on the web. There's a lot of things you got to ask, and you can really get a lot of information. You're going to ask them what position they were in. Did they smell anything funny? How long were they out for? Did anybody see it? Did they have vagal symptoms? Were they confused afterwards? I mean, were they confused? Were they postictal? Did they have any prodrome? Lack of prodrome is a very bad sign. If it just happens instantaneously, it's a bad sign. I hear this anger amony all the time from patients. Anybody know what that is? That's a sense of impending dread. It's classic for patients who are having an intrathoracic catastrophe, like an MI or a dissection, where they have this sense of impending dread. And it's also frequently described by patients with vasovagal syncope. If they have injuries, if they have a severe injury, that's usually indicative of a profound episode of syncope. Did anybody see anything? Were there any witnesses? Nowadays, everybody's got cell phones, and everybody's videotaping all the time. And I have patients come in all the time. Their family member says, "Look, I took a picture. You want to see it?" And it's amazing. I should put a reel together of those. Tongue biting or incontinence are classic symptoms of seizures, but they can happen with vasovagal as well. If a patient has a profound vasovagal syncopal event, profound prolonged hypotension or cardioinhibitory response, we frequently see those occur. Then there's the low risk. It's happened a lot before. Nothing's ever happened to me. I do good. Their EKG's normal. Their physical's normal. You're in one of the satellites that has an echo. They go down the hall and get an echo. That looks normal. They had typical vagal symptoms. They were nauseated, diaphoretic, all those things. You say, well, it's probably vasovagal. And then you also have to say, well, what's going to happen in the future? Of all the comers that show up with syncope, up to a third will have it happen again. If you're over 40 and your risk is low, you may have 20% recurrence in 10 years, or 2 years. If you've had 3 episodes of syncope in your life, you're going to have it happen again, up to 50% at 2 years. If they have a high number of episodes of syncope, that certainly suggests vasovagal. If they have an extreme high number of syncopal events, that's usually something like pseudosyncope, pseudoseizure. You can ask a few simple questions. Back in the 90s, Hugh Calkins, who was head of cardiology and EP at Hopkins, started to look at questionnaires and a few simple things that can predict, bad things like VT or heart block versus vasovagal. And if they've never had syncope before in their life, if they're a male and their age is over 50s, and that's been ratcheted down now to like 46, and they had no prodrome, those are all bad things. On the other hand, if they had vagal symptoms prior, if they had all those things, that points to neurally mediated syncope. If it happened after, that points to neurally mediated syncope. So there's a lot of clues you can get from their history. If there's family history of sudden death, or they've had unexplained early death, and you have to ask the patients, did anybody in your family ever die suddenly? And if they say, yeah, but it was a drowning, my dad drowned. Why did he drown? Or it was a single automobile accident, they never figured out what happened. Or they say he had an MI when he was 35 or 40. They didn't always do posts, and you have to look at that, and you have to say, well, maybe that was something worrisome. If they have some vagal type disorders like migraines or childhood fainting, or an athlete, their EKG shows early repolarization, that points to vasovagal. If they've had many episodes, again, that's probably suggestive of vasovagal syncope. You're going to check their blood pressure, and you're going to check it, and you're going to look for a drop. And if you see a drop, it may be a clue. Most of the drops are pretty obvious that I see. They come and they have profound drops in blood pressure, like multisystem atrophy or patients with Parkinson's disease. They're going to have a big-time drop. Here's another. That's Janet Reno fainting a few years ago. She had Parkinson's disease, and so every time she would try to be at the podium, she'd go down. She was pretty tall, too. Look how tall she was. It's like the whole stage. You're going to look at the EKG. You're going to see some EKGs today. Kurt's showing the EKGs. You got to make sure you look at the EKG before they leave. You don't want to miss a long QT or this abnormal T waves anteriorly, suggestive of rhythmogenic right ventricular dysplasia, or Brugadas. This is being reported now more and more. People are picking this up more and more. ST segment elevation, right bundle branch in V1 and V2. These are bad things. Fortunately, they're rare. This one, not so rare. Trifascicular block, patients show up, Patients show up with this syncopal event, trifascicular block, high risk of Mobitz 2 and complete heart block. You see that, patient needs to come into hospital. And so a lot of patients do go to the emergency room. Coming to the emergency room with a syncopal event is not that benign. Up to 1% of them are going to be dead within 7 to 30 days. So whatever caused their syncope can kill them. It's 1%. So it's only 1 out of 100, but it can be a bad sign. Or they can have severe non-fatal outcomes, including injury from their syncopal event, or a serious new medical diagnosis, like they have syncope and they come in and it's an MI, or they have syncope, they come in and need a heart cath. That's like 8%, almost 10%, 1 out of 10 who show up in emergency rooms may have something bad happen, even while they're in the ER. And it's 5%, another 5% in the following 30 days. The evaluation in the ER used to be pretty hodgepodge. They would do lots of different tests. Everybody that went to Hillcrest with a syncope got a CT or an MRI of their head, or they got a CT angio to rule out PE. And really, it was kind of haphazard. But people now, with the guidelines, we've looked at it, and these are important to know, not to actually have committed to memory, but know if they've had heart failure or shortness of breath, or if they have low blood pressure, or their EKG is abnormal. Sometimes you get lucky and the EKG just tells you what's going on. They have Mobitz 2, they have sinus bradycardia, profound sinus bradycardia. And there's these risk stratifications now that are available. And the ER actually uses them to predict mortality and which patients need to be admitted. I mentioned you might want to do a monitor. Holters are useless because if you have infrequent events, it's not going to get anything. You're going to want to go with event recorders. If you want to do anything more than that, you'll probably refer them to cardiology. This is what you might find, bradycardic pause in a patient with neurally mediated syncope, or you might see 2-to-1 AV block or some non-sustained VT, and then, you're going to send them. This is what you don't want to see, and this is what we see occasionally. If you see this, you've ordered the wrong test, because this happens. I also am the director of the Holter lab at the Cleveland Clinic, and a couple of times a year we get a Holter from a satellite. Family member brings in, patient died while they were wearing the Holter. And so, some patient was seen somewhere, they had some symptoms, a Holter was put on, and then they died. So you're going to want to choose the Holter that gives, the monitor that gives you the highest yield. If you're going to send them to cardiology, they may get an implantable loop recorder. These things have really helped a lot. In fact, every algorithm right now puts the loop in early. There's an example of bradycardia. I'll just say a couple of words about vasovagal. It's the most common cause of fainting. 60% of the population may have an episode at some point in their life. There's our President Bush. And we all know the features: dizziness, lightheadedness, tunnel vision, shortness of breath, yawning, diaphoresis, and then they faint. There's 2 types. There's a benign type, which is like happens in church, happens in a dentist's office. And there's a malignant type, where they just have no prodrome and they go right out. This was a case where a patient had 73 seconds of asystole due to vasovagal syncope, and it was malignant vasovagal syncope. Syncope, even if it's vasovagal, can have repercussions. She had a vasovagal faint, she got a concussion, transverse sinus thrombosis, now she's on Coumadin. It can happen. The slide also reminds me to tell them, they got to protect their head. You got to, some of these fainters, they're always hitting their head, so don't forget to check the head. You may refer them for a tilt table test. A lot of you in this room order tilt table tests all the time. Probably if you suspect vasovagal, you can use it. It's helpful. It reconfirms what your diagnosis is. It shows the patient what they're having, and you can confirm the benign nature of it. We're getting a lot of tilts now for POTS and other disorders, but we still get a few for vasovagal. I'm not going to go into the treatment of vasovagal. You all know it. No drugs work that well. High salt, high fluid, isometrics, all are helpful. And whether you guys have heard this or not, but beta blockers have been removed from recommended therapy for vasovagal syncope, which was for 20 years the standard therapy. And now they've been dropped down to a class 3 because they've been shown in a couple of studies that they don't work. Recently, there was an international symposium where the goal was by 2020 to have find a safe, proven, effective drug to treat vasovagal syncope. I don't know if we're going to be able to do it. People are doing research, but it's going to need some major, breakthroughs, some major quantum leaps in understanding of the pathophysiology. So we'll move ahead here now. I won't talk about pacemakers or POTS. And so when to refer? Well, you might want to refer them to a neurologist if they have syncope while they're fainting. You might, if you suspect seizures, or they've had focal neurologic deficits, they got a severe headache before or after, or if they have migraines or POTS or dysautonomia, you're going to send them to a neurologist. If you suspect they have a polyneuropathy or small fiber neuropathy, you're going to want to send them to a neurologist as well. And then the pseudosyncopes, which is, a big problem for all of us. They take up a lot of time seeing these patients that have hundreds of episodes of syncope. They'll have prolonged unresponsiveness. They'll arch their back. They look like they got tetanus. They have continuous random movements. That their eyes are closed and squeezed tightly. This is a big problem that I see. Now, fortunately, it's not that prevalent out there in the community, but a lot of patients are referred to me. The family always has video. If your kid is fainting, you're going to do something. You're not going to just sit there and videotape them. But I get, they were out for an hour this time. Look, and they're showing me the iPad. It's unbelievable. And so you're going to want to put that on the neurologist table. Do all patients with syncope need to see a cardiologist? Well, you know the answer. The answer is a definite probably not. It depends on your confidence level, how experienced you are dealing with these patients. If they've had a couple episodes in the past, or a remote episode, or no sequelae, or typical benign episodes, or you can reassure the patient. Do an EKG, probably an echo if you can, but if everything's normal, you're done. Just talk to them about high salt, high fluid, and if it happens again, then they might need to see somebody. You can risk stratify them in your office by those criteria that we said. If they've had family history of sudden death, or they've got conduction abnormalities on their EKG, or they have some terrible features to their syncope, like injuries or car accidents, or those types of things, then you're going to want to refer them or even admit them for expedited evaluation. And, if they have malignant features to their syncope, which we talked about, abnormal Holters, they have recurrent vasovagal syncope, you're going to want to refer them. If they have concerning family history, occupational concerns, it's a big problem. A lot of people that you're going to deal with this, they have one single faint, they can't be a school bus driver anymore. And then you're going to want to refer them. And the patients may ask to be referred. They may want to see a cardiologist. They may feel better. And then, of course, medical legally, the risk of bad things happening is small, but it's not zero. And so, 30 to 50% of these syncopes are always going to be unexplained, and so you're going to want to get fresh eyes. Driving is a big problem. I get a lot of referrals to determine driving. The guidelines are very ambiguous, very vague, and not helpful. It says in the guidelines here they can drive when their episodes resolve, but that could be, who knows. So what's going to be in the future? Well, there's going to be more and more syncope centers where you'll be able to send the patient in. They'll have gerontologists, electrophysiologists, cardiologists, internists who will see the patient, and they'll have improved access, so you won't have to struggle with that. And hopefully cost reduction, better outcome. more and more now, patients are getting loop recorders. In Europe, they're getting an implantable loop recorder in the emergency room if they've had more than 2 episodes of syncope. It's probably not going to happen in the U.S., but someplace along the line, there'll be earlier and earlier utilization of these loop recorders. And I guess with that, I'll quit. I'm a couple minutes over. If there's any questions, if we have time.